Chapter 3, Principles of Neoplasia. Neoplasia. Basic principles. Neoplasia is a new tissue growth that is unregulated, irreversible, and monoclonal. These features distinguish it from hyperplasia and repair. Monoclonal means that the neoplastic cells are derived from a single mother cell. Clonality was historically determined by glucose 6-phosphate dehydrogenase, G6PD, enzyme isoforms. Multiple isoforms, example G6PDA, G6PDB, and G6PDC, exist. Only one isoform is inherited from each parent. In females, one isoform is randomly inactivated in each cell by lionization. G6PD is present on the X chromosome. Normal ratio of active isoforms in cells of any tissue, 1-to-1 ratio. Example, 50% of cells have G6PDA and 50% of cells have G6PDB. A 1-to-1 ratio is maintained in hyperplasia, which is polyclonal. Cells are derived from multiple cells. Only one isoform is present in neoplasia, which is monoclonal. Clonality can also be determined by androgen receptor isoforms, which are also present on the X chromosome. Clonality of B lymphocytes is determined by immunoglobulin, Ig, light chain phenotype. Ig is composed of heavy and light chains. Each B cell expresses light chain that is either kappa or lambda. Normal kappa to lambda light chain ratio is 3-to-1, so kappa to lambda 3-to-1 ratio. This ratio is maintained in hyperplasia, which is polyclonal. Ratio increases to greater than 6-to-1 ratio, or is inverted. Example, kappa to lambda ratio is 1-to-3 ratio. In lymphoma, which is monoclonal. Neoplastic tumors are benign or malignant. Benign tumors remain localized and do not metastasize. Malignant tumors, or cancer, invade locally and have the potential to metastasize. Tumor nomenclature is based on lineage of differentiation, type of tissue produced, and whether the tumor is benign or malignant. So we have a table for examples of tumor nomenclature, and the headings are lineage of differentiation and whether it's benign versus malignant. So I'll read the column that has the differentiation, the lineage, and then the following names would be for benign versus its malignant or cancers. So for epithelium, we have adenoma, and its malignant would be adenocarcinoma. Then we have papilloma versus papillary carcinoma. As for the mesenchyme, we have lipoma versus liposarcoma, lymphocyte. We don't have a benign, it's mainly just malignant, so it's lymphoma/leukemia. And for melanocyte, we have a nevus or a mole for benign, and malignant is melanoma. Epidemiology. Cancer is the second leading cause of death in both adults and children. The leading causes of death in adults are cardiovascular disease, cancer, and chronic respiratory disease. The leading causes of death in children are accidents, cancer, and congenital defects. The most common cancers by incidence in adults are breast/prostate, lung, and colorectal. The most common causes of cancer mortality in adults are lung, breast/prostate, and colorectal. Role of screening. Cancer begins as a single mutated cell. Approximately 30 divisions occur before the earliest clinical symptoms arise. Each division, doubling time, results in increased mutations. Cancers that do not produce symptoms until late in disease will have undergone additional divisions and hence additional mutations. Cancers that are detected late tend to have a poor prognosis. Screening seeks to catch dysplasia or precancerous change before it becomes carcinoma or carcinoma before clinical symptoms arise. Efficacy of screening. however, requires a decrease in cancer-specific mortality. Common screening methods include Pap smear, detects cervical dysplasia, or CIN, before it becomes carcinoma. Mammography detects in situ breast cancer, or DCIS, before it invades, or invasive carcinoma before it becomes clinically palpable. Prostate-specific antigen, or PSA, and digital rectal exam detects prostate carcinoma before it spreads. Hemo-occult test for occult blood in stool, and colonoscopy detect colonic adenoma before it becomes colonic carcinoma, or carcinoma before it spreads. Carcinogenesis. Basic principles. Cancer formation is initiated by damage to DNA of stem cells. The damage overcomes DNA repair mechanisms, but it is not lethal. Carcinogens are agents that damage DNA, increasing the risk for cancer. Important carcinogens include chemicals, oncogenic viruses, and radiation. DNA mutations eventually disrupt key regulatory systems, allowing for tumor promotion, growth, and progression spread. Disrupted symptoms include proto-oncogenes, tumor suppressor genes, and regulators of apoptosis. Oncogenes. Proto-oncogenes are essential for cell growth and differentiation. Mutations of proto-oncogenes form oncogenes that lead to unregulated cellular growth. Categories of oncogenes include growth factors, growth factor receptors, signal transducers, nuclear regulators, and cell cycle regulators. Growth factors include cellular growth, examples PDG, FB in astrocytoma. Growth factor receptors mediate signals from growth factors, ERBB2 or HER2/NEU in breast cancer. Signal transducers relay receptor activation in the nucleus. Right, so we have another table which is labeled important carcinogens and associated cancers. In the first of 3 columns, we have the carcinogenic agent. The next column is associated cancer, and then its comments. And it is divided into 3 sections for chemicals versus oncogenic viruses, and lastly, radiation. So again, the first column would be carcinogenic agent, associated cancer, then its comments. So first section is chemicals. We have alpha toxins, which is associated with hepatocellular carcinoma, and it's derived from aspergillus, which can contaminate stored rice and grains. We have alkylating agents associated with leukemia/lymphoma, and it is a side effect of chemotherapy. Next is alcohol, associated with squamous cell carcinoma of the oropharynx and upper esophagus, and hepatocellular carcinoma. Arsenic is associated with squamous cell carcinoma of skin, lung cancer, and angiosarcoma of liver. Arsenic is present in cigarette smoke. Asbestos, associated with lung carcinoma and mesothelioma. Exposure to asbestos is most likely to lead to lung cancer than mesothelioma. Cigarette smoke, associated with carcinoma of oropharynx, esophagus, lung, kidney, bladder, and pancreas. Most common carcinogen worldwide. Polycyclic hydrocarbons are particularly carcinogenic. Nitrosamines, associated with stomach cancer, found in smoked foods, responsible for a high rate of stomach carcinoma in Japan. Naphthylamine is associated with urothelial carcinoma of bladder, derived from cigarette smoke. Vinyl chloride is associated with angiosarcoma of liver. Occupational exposure used to make a polyvinyl chloride, PVC, for use in pipes. Nickel, chromium, beryllium, or silica is associated with lung carcinoma. and it is a occupational exposure. Now we are looking at oncogenic viruses. So I'll read the agent and its associated cancer. So we have EBV, associated with nasopharyngeal carcinoma, Burkitt lymphoma, and CNS lymphoma in AIDS. We have HHV8, associated with Kaposi sarcoma. We have HBV and HCV, associated with hepatocellular carcinoma. We have HTLV1, which is associated with adult T-cell leukemia and lymphoma. We have high-risk HPV example subtypes of 16, 18, 31, 33, associated with squamous cell carcinoma of vulva, vagina, anus, and cervix, and adenocarcinoma of cervix. Last section is radiation, and again, we'll be reading the agent, its associated cancer, and comments. Radiation. Ionizing, so nuclear reactor accidents and radiotherapy, associated with AML, CML, and papillary carcinoma of the thyroid. Generates hydroxyl free radicals. Non-ionizing, so we have UVB sunlight is most common source, associated with basal cell carcinoma, squamous cell carcinoma, and melanoma of skin. Results in formation of pyrimidine dimers in DNA, which are normally excised by restriction endonuclease. RAS, or RAS, is associated with growth factor receptors in an inactive GDP-bound state. Receptor binding causes GDP to be replaced with GTP, activating RAS. Activated RAS sends growth signals to the nucleus. RAS inactivates itself by cleaving GDP to GDP. This is augmented by GTPase activating protein. Mutated RAS inhibits the activity of GTPase activating protein. This prolongs the activated state of RAS, resulting in increased growth signals. Cell cycle regulators mediate progression through the cell cycle of cyclin and cyclin-dependent kinase. Cyclins and cyclin-dependent kinases, or CDKs, form a complex which phosphorylates proteins that drive the cell through the cell cycle. For example, the cyclin D/CDK4 complex phosphorylates the retinoblastoma protein, which promotes progression through the G1/S checkpoint. Tumor suppressor genes regulate cell growth and hence decreases or suppress the risk of tumor formation. P53 and RB retinoblastoma are classic examples. P53 regulates progression of the cell cycle from G1 to S phase. Right, so we have another table, and we have the factor of the receptor. The first column would be its function, then its mechanism, and then the associated tumor. So first is growth factor section. We have PDGFB. This is the platelet-derived growth factor. Its mechanism is overexpression, autocrine loop, and associated with astrocytoma. Growth factor receptors. We have ERBB2 or HER2 or NEU. Function of epidermal growth factor receptor. Mechanism is amplification and associated with subset of breast carcinomas. We have RET or RET. Function is neural growth factor receptor. Mechanism is point mutation associated with MEN2A, MEN2B, and sporadic medullary carcinoma of thyroid. We have KIT or KIT. Function is stem cell growth factor receptor. Mechanism is point mutation. Associated tumors is gastrointestinal stromal tumor, GIST. Next section is signal transducers. Excuse me. We have RAS gene family. Function of GTP binding protein. Mechanism is point mutation associated with carcinomas, melanoma, and lymphoma. ABL, function tyrosine kinase, mechanism of translocation 922 with BCR, associated tumor CML, and some types of ALL. Now we have nuclear regulators. We have c-MYC, transcription factor, translocation 814 involving IgH, associated with Burkitt lymphoma. We have NMYC, transcription factor, amplification, neuroblastoma. LMYC, transcription factor, amplification, lung carcinoma, small cell. Cell cycle regulators. CCND1 or cyclin D1, function is a cyclin, mechanism is translocation 1114 involving IgH associated with mantle cell lymphoma. We have CDK4, function of cyclin dependent kinase, mechanism is amplification associated with melanoma. In response to DNA damage, p53 slows the cell cycle and upregulates the DNA repair enzymes. If DNA RNA is not possible, p53 induces apoptosis. p53 upregulates BAX, which disrupts BCL2. Cytochrome C leaks from the mitochondria, activating apoptosis. Both copies of the p53 gene must be knocked out for the tumor formation, the Knudsen two-hit hypothesis. Loss is seen in greater than 50% of cancers. Germline mutation results in Li-Fraumeni syndrome. The second hit is somatic, characterized by the propensity to develop multiple types of carcinomas and sarcomas. RB also regulates progression from G1 to S phase. RB holds the E2F transcription factor, which is necessary for transition to the S phase. E2F is released when RB is phosphorylated by the cyclin D/cyclin dependent kinase 4 CDK4 complex. RB mutation results in constitutively free E2F, allowing progression through the cell cycle and uncontrolled growth of cells. Both copies of RB gene must be knocked out for tumor formation, the Knudsen two-hit hypothesis. Sporadic mutation. Both hits are somatic. Is characterized by unilateral retinoblastoma. Germline mutations results in familial retinoblastoma. Second hit is somatic, characterized by bilateral retinoblastoma and osteosarcoma. Regulators of apoptosis prevent apoptosis in normal cells, but promote apoptosis in mutated cells whose DNA cannot be repaired. Example is BCL2. BCL2 normally stabilizes the mitochondrial membrane, blocking release of cytochrome C. Disruption of BCL2 allows cytochrome C to leave the mitochondria and activate apoptosis. BCL2 is overexpressed in follicular lymphoma. Translocation 1418 moves BCL2 on chromosome 18 to the IG heavy chain locus on chromosome 14, resulting in an increased BCL2. Mitochondrial membrane is further stabilized, prohibiting apoptosis. B cells that would normally undergo apoptosis during somatic hypermutation in the lymph node germinal center accumulate, leading to lymphoma. Other important features of tumor development. Telomerase is necessary for cell immortality. Normally, telomere is shortened with serial cell divisions, eventually resulting in cellular senescence. Cancers often have upregulated telomerase, which preserves telomeres. Angiogenesis, production of new blood cells, is necessary for tumor survival and growth. FGF and VEGF, angiogenic factors, are commonly produced by tumor cells. Avoiding immune surveillance is necessary for tumor survival. Mutations often result in production of abnormal proteins, which are expressed on MHC class 1. CD8 T cells detect and destroy such mutated cells. Tumor cells can evade the immune surveillance by downregulating expression of MHC1 class 1. Immunodeficiency, both primary and secondary, increases the risk for cancer. Tumor progression, tumor invasion and spread. Accumulation of mutations eventually result in tumor invasion and spread. Epithelial tumor cells are normally attached to one another by cellular adhesion molecules. Example, E-cadherin. Downregulation of E-cadherin leads to dissociation of attached cells. Cells attach to laminin and destroy the basement membrane, collagen type 4, via collagenase. Cells attach to fibronectin in the extracellular matrix and spread locally. Entrance to the vascular or lymphatic spaces allows for metastasis or distant spread. Routes of metastasis. Lymphatic spread is characteristic of carcinomas. Initial spread to regional draining lymph nodes. Hepatogenesis spread is characteristic of sarcomas and some carcinomas. Renal cell carcinoma often invades renal vein. Hepatocellular carcinoma often invades hepatic vein. Follicular carcinoma of the thyroid, and choriocarcinoma. Seeding of body cavities is characteristic of ovarian carcinoma, which often involves the peritoneum. Omental caking. Clinical characteristics. Clinical features. Benign tumors tend to be slow-growing, well-circumscribed, distinct, and mobile. Malignant tumors are usually rapid-growing, poorly circumscribed, infiltrative, and fixed to surrounding tissues and local structures. Biopsy or excision is generally required before a tumor can be classified as benign or malignant with certainty. Some benign tumors can grow in a malignant-like fashion, and some malignant tumors can grow in a benign-like fashion. Histologic features. Benign tumors are usually well differentiated. Characteristics include organized growth, uniform nuclei, low nuclear to cytoplasmic ratio, minimal mitotic activity, lack of invasion of the basement membrane or local tissue, and no metastatic potential. Malignant tumors are classically poorly differentiated or anaplastic. Characteristics include disorganized growth or loss of polarity, nuclear pleomorphism and hyperchromasia, high nuclear to cytoplasmic ratio, high mitotic activity with atypical mitosis, and invasion through the basement membrane or into local tissue. Metastatic potential is the hallmark of malignancy benign tumors. Metastatic potential is the hallmark of malignancy. Benign tumors never metastasize. Alright, so we have another graph. It is labeled common immunohistochemical stains and target cell types. We have the left column is the immunohistochemical stain, and then the right column is the tissue type. We have the intermediate filaments. So the stain is for keratin, tissue type is epithelium. Vimentin is for mesenchyme. Desmin is for muscle. GFAP is for neuroglia. Neurofilament is for neurons. Other immunohistochemical stains and their tissue types include PSA for prostatic epithelium. We have ER for the breast epithelium. We have thyroglobulin for thyroid follicular cells. We have chromogranin for neuroendocrine cells, example small cell carcinoma of lung and carcinoid tumors. We have S100 for the melanoma, schwannoma, and Langerhans cell histiocytosis. Immunohistochemistry is used to characterize tumors that are difficult to classify on histology. Serum tumor markers. Proteins released by tumor into serum, example PSA. Useful for screening, monitoring, response to treatment, and monitoring recurrence. Elevated levels require tissue biopsy for diagnosis of carcinoma, biopsy of prostate with elevated PSA. Grading of carcinoma. We have microscopic assessment of differentiation, how much a cancer resembles the tissue in which it grows. Takes into account architectural and nuclear features. Well differentiated is low grade, resembles normal parent tissue. Poorly differentiated is high grade, does not resemble parent tissue. Important for determining prognosis. Well differentiated cancers have better prognosis than poorly differentiated cancers. Staging of cancer. Assessment of size and spread of a cancer. Key prognostic factor, more important than grade, determined after final surgical resection of the tumor. Utilizes TNM, staging system, so T for tumor, size and or depth of invasion, N is the spread to the regional lymph nodes, second most important prognostic factor, and M stands for metastasis, single most important prognostic factor.